have to get 2 pens, ask the patient to hold both the pens like this, and then you ask the patient, you stand in front of the patient and ask them to, this is supination, and then you do pronation. So ideally you are supposed to have it fully, this much degree is 100, it goes into 0, and then it comes into basically 100. Okay, so around 50 degrees of supination and pronation on both sides. For Medprone, you do it both ways. So you'll have to do all of these tests together when they are asking you forearm or supination. Now we have hip movements. Hip movements generally not usually kept, however, if they ask, hip is similar to your shoulder. So you have flexion, you have extension, you have abduction, you have adduction, and then you have internal and external rotations, which can only be demonstrated by, you will have to basically, these are internal and external rotations. So if you are doing it on a patient, you will have to make the patient lie down and then turn their legs internally or externally. However, that is not usually kept for OSCE because it's a much more longer test. That's why it is naming, you know the names of the test. Now ankle and subtalar joint, sometimes they ask. So ankle and subtalar joint, you have ankle joint has only 2 movements. You have dorsiflexion, plantar flexion. Subtalar joint, on the other hand, subtalar is just below the ankle joint. You have inversion and eversion movements. So inversion and eversion movements are the movements at your subtalar joint. So when you are asked about these, you will have to mention all 4 of these: ankle, dorsiflexion, plantar flexion, subtalar, inversion and eversion. And just show you, otherwise you guys won't know exactly how to do it. So whenever you are going to do dorsiflexion, plantar flexion is pretty simple, it's just up and down. But when you are doing subtalar, so this joint you will have to hold, and then you are going to go here and pivot. So this is inversion. You have to completely dorsiflex the foot and then hold it completely, and then inversion, eversion. There will be a small movement. It's probably around 15 degrees and around 30 degrees on one side. So that is your inversion and eversion. So that's what. Now you have your measurements. So these are the major movements that they're going to ask you, and the exam always has shoulder. Shoulder is always does, pronation, supination is always does. Hip and ankle subtalar, less than measurements, they will always ask you. They will ask you to measure your upper limb. Now how will you measure? You will have a particular point. So measurement for your upper limbs will start from most commonly, the upper limb. Firstly, you have the angle of acromion. So you go around the border, and the most prominent point over there is your angle of acromion. First point. Second point, lateral epicondyle. So angle of acromion to lateral epicondyle gives you the length of your arm. Then you have length of your forearm. You already have your lateral epicondyle. Next one, radial styloid. So what will you do? To make it easier, if you have the time and a pen, mark on both sides. 3 points you mark, and then you measure. So you have, let's say, 40 centimeters. You measure here, there's 42 centimeters. So that indicates that either this is shorter by 2 centimeters or this is longer by 2 centimeters. Always there's no lengthening that usually happens. So you'll say that the right arm is shorter by 2 centimeters. We'll have to say it both for the arm as well as the forearm. Now you have measurements in the lower limb also. Lower limb, how will you measure? You will have to take anterior superior iliac spine. That's your first point. Second point, that is your medial joint line. So basically you just go along the medial side of your knee and you will feel wherever your joint moves. So that is your medial side of the joint. So now this is basically going to the lateral side, but ideally it has to go to the medial side. This photo is long, so don't follow this photo. You will take your anterior superior iliac spine here. This line will go up to your medial joint line here. And from there it will go down up to the medial malleolus. So those are your 3 points. So the first 2 will give you the length of your femur or your thigh. The second 2 will give you the length of your leg or your tibia. Okay. And in leg there is something called as, the next question is what is true and apparent length. So true length is what I mentioned right now. Apparent length does not have these separate points. You just take a standard point on your body. For example, sternum or your umbilicus, and you measure it directly down to your medial malleolus. So true length, ASIS, medial joint line, medial malleolus. Apparent length, sternum or umbilicus to medial malleolus. Now you will also be asked to measure circumferences. All of these have to be done both sides. Okay? Circumference. Now circumference, it is at the only point about circumference is that circumference, there are of maximum width, maximum girth. Now, often maximum girth will be often difficult in places like that. As you go proximally, it becomes more and more bulky. But the next way you can do it is if you take a particular point, fixed point from a bony landmark, and that is what is usually followed. And you can have a standard thing. For example, you can take, let's say, you keep your hologram, and then you put from there, you take 10 centimeters down, 15 centimeters up. You go for your knee also, you can put your patella upper surface, and then from there 10 centimeters and 15 centimeters. However, that is a standard thing that you can keep. Sometimes they might ask you, what would you do for a small child? For a small child, this 10 centimeters is not going to work because that is too small. So for that, the only point is that it has to be a constant thing. If it's a small child, small arm, 2 centimeters on the hologram. You're measuring it 2 centimeters on the hologram on the left side as well as the right side. That is your only point. It should be a constant measure on both sides. You measure it circumferentially. And if there is an indifference, that indicates what? That indicates that there is a wasting. So whichever is lesser, that indicates that there is a wasting of that side. Okay, so that was with measurements. So measurements always, if they ask you to just do measurements and not length or circumference, you will have to always do both length as well as circumference. Now next thing is deformities. Now deformities, upper and lower limbs, you have mainly two things. You have varus and valgus. So normally your hand, you will have a slight amount of varus, okay? But when it goes inside, that is called as varus. When it goes outside, it's called as valgus. So that is basically measuring that. You will not be exactly asked because you guys don't have something called as, you need a like a protractor. There's something called as a goniometer. It's not usually asked for you guys, but just to know, if it's outside, it's going into valgus. If it's coming inside, it's going into varus. Similarly, the same thing applies for knees. Knees also, if the distal aspect is going inside, it's varus. Distal aspect is going outside, it's valgus. Know these deformities, and if they ask you what type of a deformity is this, you just have to mention if it's a elbow, cubitus. Knee, genu. Cubitus, varus and valgus. Knee is genu, varus. Genu, varus or valgus. Okay, now you have these specific tests which will always be asked for you. So peripheral nerves, basically, upper limb peripheral nerves are mostly asked for you. You have three major upper limb nerves: median, ulnar, radial nerve. Nowadays, radial nerve per se does not have a specific test. Radial nerve, though, always a sign that you will have this wrist trauma. Ulnar nerve and median nerve have tests, and they will be asked always. So the first test is for the median nerve, pen test. So a pen test is when you're going to keep a pen on top of the hand and you're asking the patient to touch it. Okay? So what the patient has to do is to use his abductor pollicis. So the abductor pollicis is part of your thenar muscles. You will have to demonstrate it first to the patient. You have to ask the patient to keep it on a flat platform, show this, and like I did, I'm going to show this, and then I'm going to ask the patient to do it. But suppose they are not able to do it, that means that their abductor pollicis is not functioning. That means that their patient is having a median nerve palsy. So these are the only questions. What is the muscle? What is the nerve supplying it? What are you checking in the test? Okay. Because often people tell that this is a flexor. So that is a major mistake that they do. This is not flexion. Flexion in your hand happens to be this way. And this is extension. So this is abduction, this is adduction. So abduction is what you're testing. Okay. Next is card test. So card test is when you basically have to ask the patient. So you're basically going to check for your palmar and dorsal interosseous basically. So suppose you have a paper and then you're going to ask them to hold it between their fingers. So second finger and then the other. Same two fingers you will also hold. So you will also hold and you are going to ask them to pull it. So and you are also, hold it tightly and you are going to try to pull it away. Suppose the patient, so what are we checking? We're checking the adductors. So basically your palmar and crochet are your adductors, pad and dab. So palmar and crochet supplied by the ulnar nerve, which is not working, is going to go away. They will not be able to do it. And then you can say, so what are you checking? You're checking the adductors, which muscle? The palmar and crochet, which is the nerve supplying ulnar nerve. Done. Next you have the book test. The book test is also similar to this. Book test is basically when you're supposed to hold the entire, let's say, you ideally have to use a thicker piece. So you will hold it in between. Like the card test only. But here you're putting it between your thumb and your index finger. You're holding it there and you're asking the you are going to try to pull it. So the second arrow that you see over there, you as the examiner is going to pull it. What will happen? The lower hand is the normal one. You are going to hold it adductor itself. But suppose your adductors are not functioning. Your adductor pollicis is not functioning. What will happen? It will go into flexion. Because you are trying to pull it away. Because you don't want it to be pulled away, you will try to hold it like this. Because your flexor is strong, your adductor is not. That is because your adductor alone is supplied by your adductor is supplied by the ulnar. So here basically adductor is supplied by the ulnar nerve. That's actually a mistake. Don't go with that. Your adductor is supplied by your ulnar nerve. This is basically checking for the median nerve. It's checking for your ulnar nerve. Your median nerve, which is intact, will basically function, and the flexor will come into action, and it will hold it there. So here, what are you checking? You're checking for your adductor pollicis. What is the nerve? The nerve is ulnar nerve, and this is also called. They will ask you, is there a name for this test? So when it becomes the flexor becomes working, that is called as the Froment sign. Flexor Froment sign positive. Now, Arthrospastic index is basically quite simple. This is basically for your median nerve. Median nerve again, you're basically going to ask the patient to completely clasp their fingers. When you clasp the fingers, the problem is that this one finger will still point upwards. That is because the flexors of that finger are not working. Because the median nerve is not functioning. Now, why are the other fingers not? Why is the other finger still functioning and they are able to flex? Because you still have your flexor digitorum profundus on the lateral. I mean, the ulnar side, you have your flexor digitorum profundus, which is supplied by ulnar. Now, this is a little, you might probably forget it, but your basic thing that you have to say is your first finger, usually the index and sometimes even the middle finger, has the flexor digitorum superficialis and profundus supplied by median nerve. Now, this is not functioning here, and hence you are asking the class. It will not clasp, it will stay straight. Finally, you have a claw hand. Claw hand is usually not a test per se, but it's actually a deformity where, and usually your cases do not have the claw hand, but if there's supposedly there happens to be a patient sometimes there, they could be kept for your exam. So always you have claw hand, basically you have a movement like this, where you have hyperextension of your metacarpophalangeal joints and you have flexion of your interphalangeal joints. Look at your hand itself, how it will look like when you're clawing. And it's called an ulnar claw hand only when your lateral medial two fingers are there, and it's called as a complete claw hand when all the fingers are on the floor. So, what is clawing? Which is the muscle that's affected? The muscle affected is your lumbric. What is the position of claw? Hyperextension of your metacarpophalangeal joints, flexion of interphalangeal joints. It could be ulnar if it's only these two fingers, complete if it's all the fingers. Just drop. Radial nerve does not have a per se test. The rest would be dropped, so it's just the attitude. So if it's dropped, then basically you can ask the patient to try to dorsiflex the rest. If it's not possible, then basically you go for tell that there is basically a rest stop, and the rest stop is going to be radial. There's no other test that you can check for it. Similarly, the only other test for your lower limb that they will ask you is a foot drop. So supposedly you are sitting down and your patient has a problem in their sciatic nerve. So you will have a drop. You will have a drop, and this basically the feet is always going to be in plantar flexion. Okay. So you're going to ask them to do what? Dorsiflex the leg. And if they are able to dorsiflex, well and good, there is no foot drop. But if it's always like this and they are unable to dorsiflex, there is a foot drop that's present. Next question they'll ask you, one more, last question they'll ask, if there is basically a foot drop patient, how will they walk? That is when you have something called the high stepping gait. That is one additional question they'll always ask. So foot drop patient, because if I keep walking like this, I'm going to hit the ground every time I walk. So what will I do? I try to lift up and every time, because I lift up and so I have a high stepping gait. So each time I step higher. So that's basically you're going to flex your knee and try to bring it more up and then make your step. Now last part, special test. Special test, rotate the cuff, So rotate the cuff, you will ask you firstly, what are your rotator cuff muscles? Supraspinatus, infraspinatus, teres minor, and subscapularis. They will ask you functions, that is up to you, you basically have to study. But based on those functions, you will have tests. Now, learning all the tests is not possible. Learn one test for all of these because you basically have around 3 minutes or something over there. Less than 5 minutes. So you will have to do it fast. Supraspinatus. The normal function of supraspinatus is basically to start abduction by supraspinatus testing. So it's called as a Job's test. So what you do is you ask the patient to bring their arm forward, and then you will basically give a resistance downwards, and you will ask them to lift it up. So yeah, again, like I said, again it has to always be in the scapular plane, that 30 degrees. Okay, and then you do it and ask them to go upwards, and if they have on that, if they have pain, that indicates supraspinatus is gone. Now, infraspinatus and teres minor have the same function. Their function is external rotation. So you can do one thing, that is basically you can ask the patient to just externally rotate. Give resistance. Always give resistance against the motion. If they have difficulty doing that, external rotation. Now, subscapularis. Subscapularis function is internal rotation. So you can again do similar test when you're internally rotating and giving resistance. But there is a named test called belly press test, where you're actually supposed to hold here, and then you're supposed to make your arms come anteriorly. So you can't just keep pressing here. This has to come. The elbow has to cross the body. So it has to be here, and then you press it. So if they're able to do this, this action is basically doing an internal rotation. So if they're able to do it, that's well and good. That's not having a problem. Usually your patients will not have deformities. I mean, you will not have tears in the muscle. All you have to do is just perform these tests. Next thing that they're always asking, 3-point landmark. 3-point landmark of your elbow are the 3 points here. So you have the olecranon, you have the medial epicondyle, you have the lateral epicondyle. Ideally, what are you supposed to do? Again, like I said for marking, take a pen, take a marker, put the 3 points. This will, when you have a flexion, these 3 points will always form a triangle. Now, it is told to be a scaling triangle. Some places it also says it's an isosceles triangle. So there's a doubt on that. But anyway,